I am a mother of a 2-year-old boy and a 2-month-old girl. I recently gave birth during the pandemic. I am a wife and an attorney. My name is Maria, and I am a miraculous mama.
Hey everyone, welcome back to the Miraculous Mamas podcast. I'm your host, Elizabeth Joy, and we believe in empowering women through storytelling and education, and I'm so glad that you're here with me this week. If you are a regular listener, you know that I am pregnant. I would be 39 weeks if I haven't already given birth to the baby, and I let you guys know last week too that I have some pre-recorded episodes so that there is content for whenever I go into labor and for a few weeks following, and it's all going to be really great stuff. We're still going to be continuing to learn about birth plan options, pregnancy options, postpartum options, and things like that. I have an episode coming up with a pelvic floor therapist that I'm really excited about, chiropractic care during pregnancy and postpartum, and also acupuncture and acupressure. And there are a lot of myths and there's a lot of facts and truths and just interesting statistics to learn from each of those episodes and each of those guests that are coming on. This week I have Sarah Stetina on, and she's a certified nurse midwife, and we just have a really great conversation and we go over a lot of different topics. I know in the beginning of the episodes I've been going over little snippets of research that you could add to your birth plan or things that will potentially happen during pregnancy. So we've talked about delayed cord clamping. We've talked about delayed bath and why vernix is so amazing for the baby. We've talked about group B strep positive and how diet can affect that and just the research behind that as well. And there was a couple other things that we talked about as well, that it's just so that you guys have the information to make the best possible decisions for your birth with your birthing team and to feel empowered and equipped going in. Questions that you can ask your provider and being able to open up those conversations so that when you give birth, you know all of your options. Make sure that you check out my pregnancy blog on miraculousmamas.com. I'm sharing my birth plan on there. And in my birth plan, I included in case of induction and in case of cesarean. I know that most people don't plan for a C-section, but sometimes things happen. Sometimes that's what is needed. And I think that it's really, really important to study your options for that as well so that you're not blindsided or even learning the potential things that can lead to a C-section or when that might be a good option. So, or even when it might not be. Maybe there's situations where they're like, okay, maybe we should do a C-section, and you can be like, well, what are the risks? What are the benefits? What are my alternatives? Maybe there's an alternative to it or something else you can try. Obviously, depending on the stress levels of you and the baby and everything like that. So I do have, in case of cesarean, on my birthing plan as well. And I shared that on my pregnancy blog. So make sure that you guys go to Miraculous Mamas to check that out. If you're listening, make sure that you subscribe and share this podcast with your pregnant mama friends, your new mama friends, your friends that are planning to try to conceive soon. This year, we've just had such amazing guests talking about anything from trying to prepare your body to conceive and talking with people like Dr. Jolene Brighton and Dr. Axe on how we plan for so many different things in our life, but we don't always plan to have a baby. And there's so much you can do to help prep your body for that season of your life. And they're just such amazing people to have conversations with and who have tons of research and who have been working in the field for a really long time. We also have amazing guests on who are sharing their birth stories or sharing their pregnancies with us, which I'm always so grateful for. So make sure if you guys didn't go back and listen, I know during all the beginning of all the COVID stuff, everyone's life was really, really crazy. But in April and May and June, we had some really, really awesome guests on. So make sure that you go back and listen to those episodes if you haven't yet. Subscribe, leave us a 5-star review, and tell me what interviews you've been liking or what subjects you want to hear. You can find us on Instagram and Facebook, Miraculous Mamas, and also on Twitter. All right, I'm going to go ahead and get Sarah on so you guys can just hear this amazing interview and the awesome information that she has to share with us. All right, everyone, I'm here with Sarah Stetina. She's a certified nurse midwife, and we are going to have an awesome conversation today about the midwifery model of care, and also to bust some common misconceptions that people have surrounding midwives, and to just dive deeper into the conversation. So thank you for being here.
Thanks for having me. I'm excited.
So tell us a little bit about yourself and how you got into this occupation.
So I decided I wanted to be a midwife when I was in nursing school. So I had already started the nursing school process and was in my OB rotation when I saw my first birth, and I was just amazed. OB was not something that I thought I wanted to do, but once I was kind of in that rotation, it really resonated with me. And the first birth that I saw was kind of a negative one. There was just like a lot of yelling at the clients, and I'm standing in the corner crying, thinking about how beautiful this all is, and I can't believe kind of how she's being treated. And so I mentioned to my clinical instructor at the time, like, that was amazing, but it just seemed like no one in the room thought it was amazing like I did. And I don't know why they were telling her she was doing things wrong. They were kind of like telling her she wasn't pushing great, even though she was, even in hindsight now, looking back. But, and my instructor, her name's Maureen Waller, she said, you know what, you would really like midwives. And I was like, what is a midwife? I've never even heard that term before. And she was really great about including midwifery in our discussions and lectures of like the role that midwives can play, and kind of was the first to present this idea of advanced practice nurses, and that nurses could be providers, and that you could go on in your education and be the one that provides the care. And that was really exciting for me to think about. And by the time I graduated, I knew that midwifery made the most sense. It seemed like the standard, it should be the standard. And I thought it was strange that it was kind of the exception, and that not a lot of people were using midwives or even knew about midwives. And the more that I kind of immersed myself in it, the more I fell in love with it.
Mm-hmm. We're going to take a quick break from the episode so I can share with you something that has made my life a lot easier lately, and that is Sunbasket. I have been so busy preparing for the baby, trying to get stuff done at home, and also trying to avoid heavily public places like grocery stores and stuff like that. So I love being able to have delicious meals full of organic, fresh produce delivered straight to my door, and I don't have to think about meal planning or prepping because my mind is so full of other things that I need to do right now. And they are a great company. So Sunbasket, they deliver fresh, healthy, delicious meals straight to your door. They have recipes for all kinds of dietary preferences, including paleo, gluten-free, Mediterranean, vegetarian, and more. They make it very easy and convenient with everything pre-portioned and ready to prep and cook. You can enjoy a dinner full of organic, fresh produce and clean ingredients, which you guys know that I love, in as little as 15 minutes, no matter how much experience you have in the kitchen. Each week, Sunbasket offers a wide range of meals to choose from, so you can try mouth-watering dishes like roasted salmon with miso glazed eggplant, black bean tostadas Diablo with cabbage slaw and guacamole, hoisin steak strip lettuce cups with pickled daikon and carrots. You can order from any meals across their menu. You can skip a week whenever you need, or even double up on your favorites. It's as simple and easy with no gotchas involved. So I just received my second order from them. And in my first one, I got this amazing salmon verde that I loved. And I am also obsessed with buttered chicken. Indian food is one of my favorite foods. So we tried the Indian chicken which was amazing. And the chicken parm burgers were so good. And what I'm actually making today that I'm excited about is, 'cause I'm feeling kind of cozy, is their chili with some yogurt sauce. Oh my gosh, it looks so good. I cannot wait to eat it. And it's just been, like I said, so nice being able to have fresh, organic produce and clean food delivered to my door. So it's something that I just don't have to think about. And it's also something great to have for after the baby, or if you know friends who are having a baby, you can, this is something that you can gift them so that they have food coming to them as well. And right now, Sunbasket is offering $35 off your order when you go right now to sunbasket.com/mamas and enter promo code mamas at the checkout. That's sunbasket.com/mamas and enter promo code mamas at the checkout for $35 off your order. Sunbasket.com/mamas and enter promo code mamas. Now back to the episode. So for those of you listening, I actually worked with Sarah. So it's hard for me I picture you just like as a little girl, always knowing that you wanted to be a midwife because you're so passionate about your work.
Yeah.
And so amazing at it. So I'm
Thank you.
She probably knew her whole life. Like,
I think I knew most of my life that I wanted to be in healthcare.
Yeah.
And I've had that, and like that nurturing component of healthcare, not so much medicine, but caring for people when they are feeling vulnerable, providing comfort to them. That's always, I was a lifeguard. There's a lot of kind of themes throughout my life where that was the direction I think I knew I was headed, but we're actually working with birthing people was something I never pictured myself doing. So It feels so right now. I can't even imagine being in any other field. And I remember so many people telling me that I was going to get bored with midwifery, like just doing labor and birthing. And obviously midwives do way more than that, but there is nothing boring about, and even as you as a doula, there's nothing boring. Every birth is so different. Every labor experience is so different, and it makes you challenge your own knowledge every single time. So it's been really great.
Yeah. I would love to dive into the training and education. So I know that there's 2 different kinds of midwives. But in order to practice in Illinois, you have to be a CNM, correct?
Yes. Currently, certified nurse midwives are the only legal provider in Illinois. But there's more than just 2 midwife types. Okay. And that's kind of what makes midwifery kind of confusing, or there's a lot of misconceptions about midwifery because there's so many different entries. So the first, obviously, is nurse midwifery. That's what I am. And it made the most sense for me to choose nurse midwifery because, like I said, I didn't learn about midwifery until I was already in nursing school. So it made sense to go on and get my master's degree and specialize in midwifery. And so that route is a master's degree. It can also be a doctorate degree. And it's similar to a nurse practitioner, which is also a master's program, but you have the same education to a certain point, and then they branch off into your specialties. So you could be a neonatal nurse practitioner, you could be acute care nurse practitioner, family nurse practitioner, a nurse anesthetist, or a nurse midwife. All of those things are kind of in the same level. It's just our specialty that varies. And so that was, my education was going to finish my master's degree, doing clinicals and didactic, and doing births, and also doing clinic and office visits and learning all of the skills. And then you have to sit for a national certifying exam and pass that to become certified. And then you have to apply for licensure in your state. So there are other routes. There's also certified midwives, which are also take a certifying national exam and may go through an accredited program, but they're not nurses first, and it's not a master's of nursing degree. It's a midwifery degree, and that isn't legal in every state. There's certain states that allow certified midwives. And then the third is a certified professional midwife, which is also certified by a national exam. And there are midwifery programs for CPMs, or certified professional midwives, but they're not recognized in every state. I think it's up to like 32 states now that recognize CPMs. Most of them work in an out-of-hospital setting, while nurse midwives typically work in hospital settings, but it can vary depending on the state. And certified professional midwives spend a lot of time in apprenticeship with out-of-hospital experienced midwives, learning that in addition to their schooling. So very comparable. It's just the model or pathway that you want to enter midwifery. And then there's traditional midwives, which maybe don't take a certifying exam, don't have a license, and have learned midwifery from being passed down through generations. And that's how midwifery kind of started in the United States. And there's a lot of wisdom to be gained from traditional midwives, but the country doesn't usually recognize them as legal providers.
Mm-hmm. Yeah. Would you say that there is a lot of misconceptions around education as a midwife?
Oh, yeah.
I think a lot of people think you don't know what you're doing.
Oh, yeah. I think a lot of people don't realize, they compare us with doulas, which
right. People ask me all the time, oh, so you deliver babies? I'm like, no.
Yeah. Or when I tell them I'm a midwife, they're like, oh, so like a doula. And I'm like, well, no.
Not at all.
And it's so interesting. Once I learned everything about midwifery, you just assume that everyone else is going to figure it out too, which obviously is not the case. I was in nursing school and didn't know what midwife was.
Right.
But the campaign in the 1900s that kind of discredited midwives, which was led by the, Physicians and Medical Association to get people to birth in a hospital, they kind of told the story that midwives were dangerous and uneducated and not safe. And that was a really successful campaign because it is still prevalent in the way that people think about midwives today. And so I'd say whether you're a CPM, a CM, or a CNM, or choosing those providers, most of them are very, very educated and have a lot of knowledge and are experts at normal physiological birth. And midwives, nurse midwives in particular, we can prescribe, we can order imaging, we can do lab work, we can manage normal gynae stuff. So whether that's a pap smear, irregular cycles, birth control, throughout the lifespan. And I don't think people realize that we don't just do pregnancy and birth. Like you can come see me for anything that you'd go see an OB for the most part. And if it's out of my scope, I'm going to refer you appropriately. And there are levels of scope and of practice. But yeah, for most people, you can see a midwife for pretty much everything related to reproductive health.
Right, which leads us to another misconception. Because honestly, I didn't really know that before, because my introduction to midwives was my sister when she was pregnant with her oldest, who's 12 now. She didn't plan on using a midwife. She had some crazy thing happen with her insurance, dropped her because her doctor mixed up her medical records, and then they wouldn't take her, and she got pregnant, no insurance, started looking at alternative methods and found this midwife. And ended up doing an at-home water birth. And that was my first experience seeing a birth, and just fell in love with it. And she ended up having all 4 of her kids at home. And I also just fell in love with her midwife. She was a doctor in Venezuela. She studied birth in the Amazon. She came to the States and started this practice, and
very wise. I'm sure.
My gosh, she's so amazing. And so it's cool because then once I became a doula, I got to work with her with some other births too. But before that, also you picture a midwife. It's a home birth. It's, and that's all that they do is birthing.
Right.
And obviously now that I know, it's I'm going to use midwives for the rest of my life until I'm in menopause. You know what I mean?
Yeah.
I can still go to them, not just when I'm having a baby.
Right. You can have that relationship-based care, that really holistic approach in every aspect of your healthcare pretty much. And we're trained as nurse midwives, we're trained in primary care as well. So basic primary care, your annual exams, even just asthma management, simple things, we are very capable and trained to manage as well. And yeah, for the myth that midwives only do home birth, that's really prevalent. I tell people I'm a midwife and they immediately assume that I'm delivering babies at home, which there's nothing wrong with that. Obviously, your sister had a wonderful home birth, but you can find midwives in literally every setting, whether it's home, birth centers, hospitals, clinics, federally qualified health centers, academia, doing research. We're everywhere that a physician might be.
I'd love to dive into that a little bit because I think that's a huge misconception. And I think a lot of people believe that, well, if I'm going to give birth in a hospital, why not just use an OB? But there is a different approach to care.
Oh, definitely.
I'd love for you just to speak on that.
So the midwifery model of care, sometimes people think of midwives as just like a step down from a physician. Like we're less than, we're like a subpar choice, which is totally wrong. There's two distinct professions, obstetrics and midwifery. And I think some people forget that we're two different professions, that we're not just, a subset of obstetrics. And so what defines our professions is the way that we approach care. And so the obstetric model is based on the medical model of care, which is very intervention-based and diagnostic-based and reactive to problems, right? We are finding the problem and we're fixing it. And that's really important for most ailments and conditions and problems. But the thing is that pregnancy is not a problem. It's not a disease. It's a normal physiological process most of the time. And so what the midwifery model of care is it recognizes that preventative care is key. So what can we give you in education-wise and information-wise to keep this pregnancy healthy and low risk? And understanding that relationship component that people really want to feel like they trust their provider, and that takes time. So midwifery visits are usually longer and more focused, again, on that holistic approach. You are not just a uterus or a baby in a uterus or a pregnancy. We are looking at every aspect of your life that is maybe affecting this current pregnancy or any point in your healthcare, and building that rapport and that trust and knowing what you need, because it's very individualized. And these are very generalist things. There are several physicians, even some that I know, that practice in the same way, right? They are very holistic and embody a lot of the midwifery model of care. So this is just the standard. And so I don't mean to generalize, but for the most part, this is the case. And so the unique thing about midwifery care is that it is the standard of care in the rest of the world. So in the UK and other developed nations, midwifery is you enter care with a midwife. That's the standard. And the only time that you see an obstetrician is if something becomes higher risk. 90 to 95% of the time, pregnancies are for low-risk people. You're young, healthy, you're at the prime of your life. Pregnancies tend to happen to people who are healthy or, in a position where they can support a healthy pregnancy. And so most of the time, pregnancies are just fine. It's that small percentage that maybe need a higher level of care. So it's kind of, I always explain it, it's like if you needed an annual checkup and you started by going to see a cardiologist. Like that doesn't really happen. You would go to your primary care doctor, and if there was something detected that for your heart, then you'd be referred to a cardiologist for that higher level of care. So midwifery is the same. We should be the entry point for everyone. And if something becomes higher risk, then we would refer you to an obstetrician. But it's kind of backwards in the U.S., where everyone sees an obstetrician and a small percentage of people pick a midwife or even know about a midwife. And midwives have tons of evidence to support that we should be the entry-level care for pregnancy and birth. And what from lower C-section rates to lower lacerations and episiotomies, less NICU admissions for newborns. The list goes on and on, but I mean, it's pretty general consensus now that midwives are good news when it comes to outcomes. And the U.S. outcomes for birth are not good. And I think that really is because we're sending low-risk, healthy people to surgeons and specialists for high-risk conditions. It's a little backwards.
Mm-hmm. Yeah. We're going to take a quick break from the episode to talk about something that you can do to help yourself mentally. So I know that we've gone over tons of information on preparing for your birth and after, but we haven't really dove into the mental side of it. And when it comes to motherhood, when it comes to pregnancy, and even with so much going on in the world, just life in general, there's so many things that can affect your happiness, that can maybe cause depression or have you maybe not in your regular thought pattern that you might be. And I just want to let you guys know that there's no shame in getting help. There's no shame in reaching out to talk to somebody. And sometimes it needs to be somebody who's not in your circle. And that's why I love BetterHelp, because they are such an amazing resource. They will assess your needs and match you with your own licensed professional therapist. You get to connect in a safe and private online environment. It's so convenient. You can start communicating in under 24 hours, and it is professional counseling. And you can send a message to your counselor anytime. And they are committed to facilitating a great therapeutic match for you. So if you don't match with somebody, they'll find you someone new. And it's available for people worldwide. And I know that it is so important to nourish our mental health as well. I have gone to counseling several times in my life, and I've actually used BetterHelp. And it's really nice to be able to just, like I said, have somebody to talk to who's outside of the situation, who's a professional and can kind of help guide you through the season of life that you are in. The one thing that's awesome about it is that it's convenient. It's always confidential, professional, and affordable. And in fact, so many people have been using BetterHelp that they are recruiting additional counselors in all 50 states. And right now we have an amazing offer for you guys. I want you to start living a happier life today. And as a listener, you'll get 10% off your first month by visiting betterhelp.com/mamas. That's BetterHelp, HELP.com/mamas. Join over 1 million people taking charge of their mental health. BetterHelp.com/mamas. Now back to the show. One thing that people asked about was, can you, as a midwife, see a high-risk person, or is there like a threshold?
So there is a threshold, but it really depends on how it is set. So the setting that the midwife is practicing is going to be really important. So a home birth or birth center is going to be limited in the clients that they can see, because they have to have that threshold be lower for low-risk people. Not everyone should be delivering out of a hospital setting. But there are certain things that may be considered higher risk for a birth or home birth, but are still appropriate for midwifery care in a hospital setting, especially in collaboration with a physician. So similar to the practice that you and I have worked at together, we have a physician in our group, and we can consult or have our clients see the physician periodically to follow up on the plan of care and kind of work as a team to determine, the best course of action, while the client is also getting that really supportive midwifery care. And so we've managed twins in this hospital practice, gestational diabetes on insulin, high blood pressure. Those things typically would risk you out of midwifery care, but if in collaboration with a physician, they can definitely be managed appropriately, and you can kind of get the benefits of both worlds.
Mm-hmm. What about VBACs?
Oh, yeah, definitely. Yeah, so midwives are probably the lead change agents in VBACs and VBAC rates in the U.S. So we are very supportive of VBACs, at least, I'm generalizing, but at least the practices that I've been in and me as an individual, we know that clients should have the option for VBAC if that's what they want, and they should be supported in that and have policies surrounding VBACs that are really setting them up for success, and not actually like VBAC tolerant policies, more VBAC friendly policies. So And VBACs can be appropriate in different settings depending on the history. So some home birth practices do VBACs, some birth centers do VBACs. It's just going to be dependent on your individual desires and also resources in those out of hospital or community settings.
Yeah, for sure. I know, I mean, it's been so cool working at the practice where I met you, because before that I had told Vito that basically almost every birth I've ever been to, I'm like, I would never choose this place to birth in. Mm-hmm. You know, and even if it was an okay experience, like I went to one that, like a hospital in Evanston before I started at Hinsdale, and it was a great experience. And her doctor was they did an induction. It took 3 days. They were hands off. There was a point where she's like, I think I need a C-section. He's like, no, you don't. Mm-hmm. You know, it's taking time, but you're fine.
Right.
And like anywhere else I was at, they're like, C-section? Sure. You know, like jump on it. We'll go ahead and do it.
Sure.
But he was like, no, I don't think you're going to need one. Like, it was very relaxed. And I'm like, okay, that was my best hospital experience before starting at Hinsdale. And then being able to work with the midwives there and just see how they viewed birth as a natural process. It's very hands off unless you really need something, or if the client really wants something.
Yeah.
Like obviously if somebody, and we do epidurals there, we do other things. So it's not like everyone coming in is doing an unmedicated birth. But if that's what they really, really want, we're going to do everything we can to give them that experience.
Yeah, absolutely. And I feel like you brought up a good point that you can get an epidural. I think there's a myth that choosing a midwife means choosing an unmedicated birth, and that's not the case. You can basically get everything that you would get at a normal physician delivery with a midwife, and then I'd like to say you get bonuses and all of the labor support that you have from a midwife that you've developed a relationship with throughout your prenatal care. And so, yeah, you get that. We don't show up at the end to catch the baby. We're there to give you suggestions on how to help labor progress and how to relax yourself and how to get pain relief and what positions would be helpful. And that goes along with just the midwifery model of care is very evidence-based. Mm-hmm. So obstetrics tends to have a lot of traditional policies, meaning, well, we've always done it this way, so we're going to keep doing it this way, rather than what is the actual research and evidence support. And we know that things like eating and drinking during labor and being able to move freely and doing intermittent monitoring, these are all evidence-based practices that midwives do on a standard routine basis that are not routine in most hospitals across the U.S.
Mm-hmm. Right.
And those things all help lead to the good outcomes that we were talking about before. And just feeling like you as an individual felt respected during birth and that something wasn't just happening to you, that you were a partner in the decisions that were being made, that you weren't having anything done to you without consent. I think informed consent and client autonomy is really important in the midwifery model of care. Everything is a conversation, and it's not this idea of like doctor knows best and you just do this because I told you to. And again, that's a generalization. Not all physicians are like that, but it does tend to be this standard experience that I hear from doulas, clients who've had those OB experiences, and even that I've seen as a labor and delivery nurse in a hospital setting, that is more of the norm than what midwives provide.
Mm-hmm. Yeah. I'd love to just touch on really quick, because I guess maybe I have a question about it, but it's also a big pet peeve of mine is, so I'm 33 and I'm having my first kid, and we plan on having more.
Right.
And I hate the fact that at 35, I'm considered advanced maternal age. And in some practices, then you're automatically considered high risk if you're over a certain age. But I know we were talking about evidence-based birth website, which I'm going to link some of their articles for this podcast here as well on midwifery care. I was listening to it the other day, and there's not a steep age where it falls off, where It's like, oh, you're 35 now. It's like from the time you're young, you start to lose fertility. You start to, your fertility ages for women very quickly. But there's not like a mark off point. And it seemed like mostly closer to like around 40 was where some numbers went up, where there might be some more high risk, but also depending on if you've had kids before that age or all of that.
First. Right.
Right.
Yeah. So we joke about advanced maternal age actually being, it's AMA is actually average maternal age.
Yeah.
Especially these days, more and more people are choosing to give birth later or having babies after 35. And we, again, are looking at the big picture, and we're giving individualized care. And I think we do a disservice to people when we make a blanket statement about risk. People say VBACs are high risk. People say advanced maternal age is high risk. But those are just factors that play into your risk level. And as long as clients are aware of what the risks are, and there's actual data that we can present to clients about, you know, at 35, the risk of Down syndrome or, you know, even stillbirth after 41 weeks. Like, let's talk about what that means in numbers and what that risk might mean to you, because, you know, 1% to you might be not a big deal, but it might be too risky to someone else. So for us to determine what someone's threshold of risk is that's not up to the provider. That's up to the individual to decide what risk they're comfortable taking. And we are just here to provide the information. So I personally have seen so many healthy, normal births after 35. But I think that there's certain things that need to be presented and information that needs to be shared that may change individuals' birthing choices, or, you know, maybe they'll have an induction a little sooner than they normally would if they weren't 45 or 40. Or, and so I think just calling someone high risk based on age alone without looking at, you know, all of the other factors, all of the actual numbers, you know, they like to say, like, VBAC's a good example, because you could say easily that the risk of uterine rupture for a VBAC is double the risk or twice the risk. And it's like, okay, but the risk is about, in a normal pregnancy might be like, what is it, like 0.5%, and in a VBAC it might be 1%. So yeah, it's double the risk, but is 1% really a high enough risk to not allow someone to try to have a vaginal delivery? That's not up to us. We just have to provide the information and give someone the opportunity to decide what that risk means for them and if they want to proceed with that plan or not. So I think the same thing applies to AMA and all of the other conditions that come up in pregnancy.
Yeah, I don't know why it just like irks me. Maybe because I'll be 35 in a couple of years. I don't know. And I plan on still having kids. Yeah. So it's like, I don't think there needs to be a line in the sand for when you can't have children anymore. Right. It's just, you have to recognize what are the risks, and evidence-based birth is a really great resource for really understanding what does the research say? Let's break it down into numbers, and what does those numbers mean to me? And I think Rebecca Decker does a really good job of doing that in a way that's really easy to understand about so many topics. So that could be a whole podcast on itself. Yeah. But yeah, I hope that helps. Yeah, for sure. So I would love to talk about a few things that I guess I hear from a lot of people. And one of them is stall outs during labor and failure to progress. So I hear from a lot of people, oh, my water broke, but my labor never started, you know? And so I had to get induced, and it was like 2 hours later.
Oh yeah.
You know, or, you know, I got there and whatever, and my labor stalled. And those are both things that end up with high intervention, but evidence kind of suggests that you may not have to, like, these things are normal.
Yeah. So there's the kind of what we call the standard of care. And that's kind of what would other providers do in this area at this hospital in this situation. Right. And the standard of care does not always align with evidence-based care. And the problem, I think, in medicine and obstetrics particularly is the failure of presenting the evidence that might differ from the standard of care and letting the client choose the path. So, for example, you gave an example of water breaking before labor, which I absolutely hate. I hate when that happens.
I know. I hope it doesn't happen to
but
me.
But it does. And it can happen, and it's okay. But
right.
It's like just I am not a big fan of that situation. But so the standard of care would say exactly what you said. Have someone come in and start an induction of labor. That's kind of the standard in obstetrics. But the evidence would say that it's really appropriate to wait up to 24 hours before starting an induction, and letting the client go into labor on their own. And Rebecca Decker talks a lot about that on her website, about even 6 hours, the percentage of people that will go into labor.
Right.
If you give it 12 hours, the percentage of people that will go into labor. And by 24 hours, a majority of people will likely be in labor on their own.
Yeah.
The factors that we play into, again, are very individual. So GBS, status, clients' desires. Maybe they are just done and they want to have an induction. And as long as they know the risks of that induction and their other options and they choose that, then that's fine. We'll support them in that. But in regards to like failure to progress, I hate that term. It's really vague, and a lot of places don't define it well. And what does it mean to have a failure to progress? Most of the time, it's really just a failure to be patient or a failure to actually be in labor in the first place.
Right.
So the term failure to progress was kind of defined by you had to set the standard of what was normal, right? So in the 1950s, Friedman set the Friedman's curve, which was basically saying normal labor should be this dilation in this amount of time. And we know now, like with more research and evidence, that his projected timelines for normal labor were so short compared to real life. When people go into labor on their own, labors tend to be much longer and dilation much slower than what he had predicted. So under his parameters, so many more people are going to have failure to progress, which is why maybe our C-section rates are so high. But now there's like really specific criteria that is recommended to be used. And again, a lot of people, it's hard to change culture in OB because of that traditional, we've always done it this way, we're going to keep doing it this way. And so instead of applying the new evidence, they're kind of sticking with that Friedman's curve because that's what they've been doing the last 60 years. So it's really important that consumers and clients educate themselves. So when they're in these situations and they're not being presented with the evidence, that they know how to advocate for themselves. So for example, like a first stage arrest, which is the term that's better to be used than failure to progress. It's a labor arrest. That has to happen once you're already 6 centimeters or more. So if you're under 6 centimeters and your labor stopped, or you're being told that your labor has failure to progress, you might still be in early labor. You might not be in active labor. And so you can't really define a labor arrest. And as long as the baby is well and the birthing person is well and stable, do we really need to intervene? Do we really need to call this an arrest and do a C-section? Like, technically, no. And then if you are after 6 centimeters, an arrest would really be defined as have you been having regular adequate contractions and you haven't made any change in 4 hours? Because that would be falling into abnormal, right? And abnormal, I mean, in the olden days, people died from arrested labor. So it can be a problematic thing that does need intervention or need a cesarean. Like, there are those situations, but it's probably way less than what's actually happening in the U.S. right now. And so having a really clear-cut, defined, like, what is arrest and when do we call it that, and are we really sticking with these definitions, that will help avoid unnecessary interventions. But you mentioned too, like, you get to the hospital and the labor slows down or stops, and that is so normal because we know that stress and fear counteract the normal hormones of labor. So cortisol and adrenaline, they have no place in labor. You cannot be fearful and progress. And a really good example is, like, we talk a lot about this in midwifery, is just the animal response. So if an animal is giving birth and they get scared, there's a predator nearby or something, their labor will literally stop so that they can run away and go to somewhere safe to have their baby. Like, evolution has shown that They can't have their baby if there's a predator near. That's too dangerous. They're too vulnerable. And so to think that we act any differently is silly. I mean, we are in a place, we go into a hospital, we're scared. There's people, there's strangers. We've never done this before. A lot of time this happens with first labors. And that adrenaline and cortisol starts pumping out, and that counteracts the oxytocin, which causes the contractions. And so labor can really stall until you feel safe again. And some people might never feel safe in the hospital, especially if they don't have supportive providers or people around them. And that makes it really challenging to have a successful birthing experience. And so part of what midwives do is we recognize that kind of emotional dystocia is what we call it. Like, what is causing this stall? Is it something that's like fear-based, or maybe you've had a history of trauma and things are coming up now, which happens a lot during labor. And so what can we do to kind of support that physiological birth again? And maybe it's talking it through. Maybe it's removing any people in the room that are not making you feel safe. It could be people that are unhappy with your choice to do it unmedicated, and keep telling you, no, you just need to do it the way that I did it. Or I was at a home birth as a home birth assistant a long time ago, and there was the client's mother-in-law really did not want her to have a home birth. She had told her throughout the entire pregnancy that this was irresponsible and that she was going to kill the grandbaby and all of these really horrible, non-productive things for this client's choice. And during labor, she was progressing really normally and doing fine for her first labor. And then her mother-in-law showed up. Her mother-in-law didn't say anything, didn't do anything, but just her presence there, like the client's labor completely stopped. Like she just completely stalled out. She was already like 6 centimeters or something. And it was like, okay, we just need to have this person leave and sure enough, like after the partner asked the mother-in-law to leave, the labor kind of gradually picked back up again. And I think it's a really important piece to remember. But there's other things, obviously, that can cause a slow or stalled labor, like baby's position is really important. That's why midwives really focus on positioning. If you move the mom, the baby will move, or you move the birthing person. But so we use a lot of midwifery, kind of traditional midwifery tactics, which is a lot of movement and positioning, and then like labor support to make people feel safe and comfortable and relieve their pain, whether it's a tub or shower. So all of those things can help, even aromatherapy. Midwives are the experts, I feel like, along with doulas, at setting a really safe and comfortable physical environment. So dimming the lights, making it smell good, making it quiet, making sure people aren't coming in and out of the room. Those are all really protective behaviors that allow someone to feel vulnerable while still feeling safe.
Mm-hmm. Yeah, I love that. And also one thing that I always tell people too is if you don't feel comfortable asking someone to leave, ask your doula, ask your nurse, and you can even blame it on them too. Be like, sorry, right now our policy is we can only have this person in here. Whatever it is. Because also I know a lot of people don't want drama in that moment. But I had a similar experience. I was at a birth where the mom had only had C-sections. Her sister had C-sections. She had a slow leak in her bag. We're at the hospital. They're coming in telling her if she doesn't get, like, her baby's going to get an infection and probably going to die because her bag's leaking and she's,
Right. That's scary.
Right. But then her family wasn't supportive of an unmedicated birth. And it ended in a C-section. And as soon as they decided to do the C-section, her sister sat down next to her and said, I told you you'd probably end up in a C-section. Aww. And I was just like, I cried so hard during that birth and after it. Like at one point, once everyone got epidurals and was like napping, I went and grabbed something to eat. And I remember calling Vito just like bawling. I'm like, I don't know how to
process this right now.
I was like, how do I keep being a really good doula without telling this family to F off? I
feel like there's a similar problem with breastfeeding too, with like families who didn't breastfeed and now this generation is trying to breastfeed and there's just like a lot of negative, well, like I didn't breastfeed, so you shouldn't either. It's too much work. It's too hard on you. And that pressure from family can be really detrimental. And I think the only thing that we can do as doulas and providers is just educate our clients so that they feel strong enough and like validated enough in their decision. Like, no, I have the evidence on my side and I have the support on my side, even if it's not from my family. I found and built my team that does know what I want. And, and I know I have, sometimes C-sections are needed, but you should have people around you cheering for you, either way, and not telling you I told you so. That's awful.
Oh my gosh. I know. So let's see. We do have some questions from a few people in the group.
Sure.
A lot of people use midwives and are like, it was the best decision I ever made. Let's see. So, a couple people asked about how do you find a good one?
A good midwife?
Yeah. How to get connected with one. Because, well, again, like you said, though, I think a lot of people don't realize. So Vito and I were having our first baby in a hospital setting with a midwife, even though to me it's not like a normal hospital setting, or at least a lot of hospital settings I've been to. But then there's also, depending on where you live, birth center options, home birth options.
Yeah.
So it depends on, I guess, first of all, where you want to have your baby.
Exactly. That's what I was going to say. First, you have to figure out what kind of setting that you want to be in. And maybe that might change as you go through your pregnancy and you realize that you may be higher risk and you can't have a birth center birth that you wanted, or, vice versa. Maybe you are fearful of having a high risk birth and then find out later you're not. You can always transfer. And even if you're listening and you're currently in a practice with a provider that maybe you don't feel like you trust, or that you don't feel like has your best interests in mind, or wants to respect the choices that you want for your birth, it's not too late to transfer. So once you figure out kind of the setting that you want, there is a website called midwife.org that is the American College of Nurse Midwives website, and they have a Find a Midwife option. There's also the Birth Center Association of Birth Centers that has a Find a Birth Center that you can kind of seek midwifery practices in your area. And then you can also call like your local hospitals and say, do you have a midwifery program? And even just doing that, whether they have a midwifery program or not, if enough people are calling and asking hospitals where their midwives are, I think they're going to realize they should have some if they don't. But yeah, just calling around, and then reviews. And I think getting just like personal feedback from people who have used midwives. I think actual feedback from someone you know and trust saying that they had a really good experience. I mean, that's how we get most of our clients is just word of mouth referrals. But yeah, midwife.org is a good place to kind of find a midwife near you. It doesn't necessarily mean they will not all midwives do birth either. Some work at like Planned Parenthood or clinics, or they only do like the clinic side, but usually if you find a midwife, they can connect you with other midwives that do birth in whatever setting that you want.
Yeah, for sure. Somebody asked, what is a number one tip for mamas in labor that you would give?
Oh my gosh. Have a midwife?
Yeah.
Yeah, that's really, and
if not, then be like highly educated.
Yeah. And I think having, and even if you're not I think everyone needs to do their research and do evidence-based research, not just, I think, no offense to like the Facebook mom groups, but everyone's anecdotal experiences does not equate to evidence. And when the standard of care is not evidence-based, someone's experience most likely does not line up with evidence. So we shouldn't be getting our main source of information based on someone else's. They broke my bag at 2 centimeters, so it's okay. Or, evidence-based birth we've talked a lot about that today, but that is a really good resource, because Rebecca kind of compiles all of the evidence that exists on topics and gives you the tools to kind of make decisions. But I think choosing a midwife is a really good first step. And then obviously I'm a huge fan of doulas, and having a doula that you connect with and that you trust is also really, really important. yeah, I mean, that's my biggest advice is like the team around you makes the biggest difference. Like the hospital that you choose to deliver in, if you're delivering in a hospital, it also determines your outcomes. The range of C-section rate or the C-section rates range dramatically from one hospital to another. And like Liz mentioned about the hospital that we met at, that's a little niche culture there that has like such a really good midwife. They've had midwives there for like 35 years. So they have a culture that's based around the normalcy of birth. And so their C-section rates tend to be lower, and they have a lot of policies that are conducive for physiological birth. And so people go there, even with the physicians, and tend to have a better experience than they would maybe at a different hospital. But there's some hospitals that have rates as high as 45% C-section rate. So, you know, just choosing where you give birth can be a determinant in the kind of birth you'll end up having.
And one thing that I learned too, so with a lot of the podcasts I've been doing lately, I link articles, evidence-based birth on there. And I recommend listening to her podcast too. I've been listening to it a lot, just preparing for my own birth. And one thing that I learned is even when this research comes out, so the standard practice that OBs practice under, like you said, it's kind of been there for a while. Like a lot of things were research that they did in the 70s, 80s, 90s, or maybe even before that they're still practicing. But there's been so many new studies in the last 20 years. Yeah. But research shows that it takes at least 15 to 20 years after research has been done to start to be put into play in practice, in OB practices.
In OB, yeah. Right. So obstetrics is the key there, because in other areas of medicine, and I saw this as a nurse, I worked on orthosurgical floor, I worked on a medical floor, you know, a new evidence could come out and it could be applied within a year or something.
Right. They're like, oh, we learned that this is no longer necessary, so we're not going to do it.
Or, you know, general surgeons are really good at applying new technology or new evidence to improve their surgical outcomes. And they do that almost immediately. But in obstetrics, for some reason, there is that, you know, I've heard 13 years, but 15 to 20 years doesn't sound too far off either of just, for example, I watched a video yesterday about delayed cord clamping that was from, like, I don't know, early 2000s. So like 20 years ago, they were talking, this OB is talking about the benefits of delayed cord clamping. And there are still facilities who are afraid of delayed cord clamping, who don't do this as a routine standard thing, even though we know it's beneficial. Right. So it's like so frustrating, because I know I read an article that's, you know, a consensus on a certain practice or evidence-based. I read something on evidence-based birth, and I'm applying it the next day or that week, you know, and so we just need to have a culture change in OB that like really respects and values evidence. Right. And also just respects client choice. I think that's a really big problem, is it's like, even if they ask for delayed cord clamping, like they're not doing it. Like, why? There's no risk. Right. You know, so it's like, why would you not? Because when I was practicing in Vegas, like 6-7 years ago, every birth I went to, the doctor would not do it. Yeah, so there's some fear. I think the concerns are that, like, okay, well, this will increase the blood viscosity of the baby, or this will increase the bilirubin levels. And those have been shown to be true, that babies who get delayed cord clamping have thicker blood and have higher levels of bilirubin by lab. But that doesn't mean that it's clinically significant, meaning we don't see that these babies are getting sick. They don't get jaundice. They don't have problems. And so just because something is showing up in a lab doesn't mean it's ever clinically relevant. And so I would agree with you that there's no harm that has been shown. And the burden of proof should really be, and this is part of one of the videos that I watched. I should send that to you. It's good. The burden of proof should be on the people who are immediately clamping. Prove to us that that is safe and not causing harm. Because delayed cord clamping is what we see in nature and what seems to be the normal physiological process. And there's so many benefits to that. It's on my mind because I just was reading about this and watching it yesterday, but like iron stores, they've shown that it really improves iron stores for up to 6 months. And, you know, there's populations even in the U.S. and around the world, it's like 1/3 of the global population is iron deficient. So if we can give the baby iron stores up until their 6th month of life, what a great head start. And stem cells, they're theoretically could help them with their preventing neonatal diseases. I mean, that's not been proven by research, but we know that there's stem cells that they get through their cord blood. But yeah, just like, it should be just like so easy to be like, okay, this is good for babies. Let's do it.
Right.
But it's so hard to convince them, even with like skin to skin,
Right.
too. Like, we know there's numerous long-term and short-term benefits of skin to skin. And when I talk about skin to skin, I think this is really important. I tell all my clients this too. It's immediate. So it's right after the baby is born. It's not like, oh, we're just going to take the baby to the warmer for 20 minutes and then we'll bring them to you. No, it's immediate. The baby, and if you're doing delayed cord clamping, it works out great because you just put the baby right on the birthing person's abdomen. And it also means uninterrupted. So that means for the whole at least the first hour of life until that first breastfeeding, if you're choosing to breastfeed, not 5 minutes and then the nurse is asking to take the baby over to the warmer. And I know a lot of hospitals that say that they do immediate skin to skin or uninterrupted skin to skin, but they're actually taking the baby within the first 10 minutes of life to go do the measurements. So you can feel really confident as a consumer or as a client to say, no, you don't need to weigh my baby or do the measurements right now. I'm going to do uninterrupted skin to skin. And that's why it's called the golden hour. It's the full hour of you being skin to skin with that baby. And that has like lifelong benefits of bonding and brain development and attachment, in addition to the immediate effects of like transitions for the baby and all that. I could talk a lot about that too.
Yeah, I know. We could have like a 3-hour podcast.
I know, we could.
But we won't. So I have a couple of fun questions for you.
Sure.
For myself. Sex after baby.
Yeah.
Do you have to wait 6 weeks?
So we usually recommend until the bleeding has stopped.
Right.
So some people that's 4 weeks, some people that's 8 weeks. So it really varies. Again, making blanket statements for anyone is never really my approach. It has to be based on what you're feeling and what your body is going through and what you want too.
Right.
So your bleeding might be done at 4 weeks, but that doesn't mean you want to have sex, and that's fine.
Right. And it might not be comfortable.
Right.
Who knows?
So it should never be super painful. The first time is always a little uncomfortable, especially if the earlier you do it, the more sensitive that those tissues are going to be, especially if you had any lacerations or tearing. Those can take several weeks to heal. So we usually recommend using lots of lubricant and recognizing that you may have to try different positions. What worked before might be not working right now in the postpartum. And then going really slow and really good communication with your partner. And I'm talking about penetrative intercourse. There's lots of different kinds of intercourse. But yeah, we usually recommend not doing any kind of penetrative intercourse until the bleeding is stopped, because the bleeding is a sign that the placental site is still healing and closing, and we don't want to increase any risk of infection going up from the vaginal canal into the uterus into that wound and causing any kind of uterine infection. So that's the theoretical concern, or not theoretical. It is a concern. So,
but could you do other things potentially? I'm not saying I don't know obviously how I'm going to feel afterwards.
There's a lot of ways to have sex.
Touch
There's a lot of ways to have sex, and there's no right or wrong. It's really whatever you want and that feels good and that you actually want to do at that time. And I think consent is a big part, and not feeling like obligated to have sex just because you're depriving your partner of sex. I don't really like that concept.
It's like I just pushed out a human, so.
Yeah, and it's really normal in the postpartum to feel touched out. You're sleep deprived. Yeah. You have a baby that's, if you're nursing, especially constantly touching your breasts, and it's normal to not want any kind of breast stimulation if you have breasts. to want that. That's really normal. So sex may look different, or what things that felt good before having a baby might not feel great after. And so just being flexible with your own desires and kind of being in tune with what feels good and what doesn't, and how can I communicate that to my partner, because your partner is not going to be able to read your mind either. And so they might just resort to things that felt good before, and that might not be the case this time. So having those conversations and trying new things that feel better. And it's really normal to have a low libido or no sex drive while you're breastfeeding. And that's just nature's birth control, right? That's, I am giving all of my resources to this human. I don't need to get pregnant right now, so I have no motivation to have sex. And that's just kind of our primitive biological process. But that can last up to the first year, especially if you throw in some mood disorders. It's going to be really normal to have it look a little bit different. But we do recommend reaching out to the midwife and having those conversations. There's nothing off topic with your midwife. You know, she has these conversations all of the time. So don't feel embarrassed to ask about sex or if something's not working. And if it's painful, then definitely tell us, because that's not normal. I think a lot of people think, oh, this is just what sex is now because I had a baby, it's always going to hurt. And that is not true. So if you feel like that, please let me know. And if your provider's not telling, or like not taking you seriously, I guess, or if you've told them and they're not giving you any solutions, then you need to find a new provider.
Right. Yeah. The other question is prenatals. I have no idea how long I'm supposed to take them after I have the baby.
So, prenatals and postnatal, there's different ones, but you can continue taking a prenatal. That's totally safe. It's not harmful at any point. But the whole reason of taking a prenatal is to kind of substitute where our diet or natural nutrients are lacking in our diet. A lot of our food tends to be like nutrient poor compared to years and years ago. So you can continue it as long as you're breastfeeding is kind of a rule of thumb. But it also depends on the kind of foods that you're eating and just your lifestyle in general. And if you're getting those vitamins and minerals from food, you might not need a prenatal. But I would say a majority of people in the U.S. could benefit from taking the prenatal while they're breastfeeding.
Yeah.
But there are postnatals, so you can get that too.
Which I haven't seen, which is interesting. I need to look that up. Postnatals.
Postnatal or postpartum vitamins.
Yeah. Perfect. I know the other day I was saying, I got this pregnancy hair, like my hair got long and it's like thicker.
Looks beautiful.
And I'm scared it's all going to fall out.
It might. Again, there's no rule of thumb, but it does tend to kind of, all of that, the new growth will just kind of, like any growth that was just starting when you have the baby will likely be the part that falls out, but it can feel very overwhelming. You're like, oh my God, all this hair is coming out.
Yeah. I feel like that's been, I've always wanted long hair. And for some reason, when I got pregnant, it got really long and I'm like, sweet. But I mean, if that's the worst that happens, I can live with it.
It'll stay long. It'll just feel thin probably.
Yeah. And last question is tips to prevent tearing.
Oh, that's a great question. Exercise during pregnancy. So, and nutrition. I will tell you that the clients that I've seen that have the worst tears or the most difficult repairs, because they have really what I call friable tissue, it's just kind of falling apart, are people that are smokers and people who have very poor nutrition. Maybe they don't have access to good food, or maybe they just choose not to eat good food. Either way. So you have to give your body the protein and minerals and nutrients to kind of create strong, stretchable tissue. And so that would be the key, would be eating really well, especially, throughout if you can, but especially towards the end. And then exercise, just pelvic floor strength. So this is kind of a balance because you don't want to be, you don't want it to be over tight or over, flexed all the time. We kind of talk about your bicep being like a flexed. You couldn't walk around with your bicep flexed all day. It would be useless. You have to relax it sometimes. And your pelvic floor also needs to be able to relax and contract. And so a balance. So all of the pelvic floor exercises, but also like practicing relaxing your pelvic floor, and looking up there's some really good like pelvic floor Instagrams that you can follow that are specific to pregnancy.
Expecting and Empowered is one of my favorites.
I think that's the one I'm thinking of.
The lady's hilarious. The main lady.
Yeah.
Yeah.
But it's really helpful. If you learn to control your pelvic floor, that will be really beneficial during pushing. And also it's normal to tear. Some tearing is very physiological. There's a reason that the vaginal tissue heals so quickly and so well. And for the most part, the vaginal canal and the perineum are very stretchy, but it is normal to tear a little bit. And so I don't want people to be super fearful of that. Most of the time you have so much adrenaline. And when the baby is crowning, there is some natural endorphins that are like that flood you. It's almost like a pseudo anesthetic in a way. I will tell you, most people don't tell me immediately like, oh, I know I tear. They're like, did I tear? I don't know. Can you look? Like, so, it's mostly the healing part that can be really sore. And there's a lot of great products for kind of helping with that. But also during labor, the squatting or like upright positions while pushing are really great for bringing the baby down, but sometimes they can increase tearing because of gravity and how quickly the baby can come out. So sometimes what we do is we have clients push in those upright positions, and as they get closer to that crowning part, we might have them do like a side lying position if that feels right to them, or maybe having more of a get in the tub or something. The tub is really helpful for preventing severe tears, like 3rd and 4th degree tears. And there's not a ton of evidence on like perineal massage during pregnancy, which is basically like practicing stretching out that tissue. But I have a lot of clients that swear by it, and it's not harmful. So you can try it. It's not comfortable. I think a lot of people think, I'm going to do this with my partner. It's going to be great. And it's like, no, it's not great. It's not fun.
No. But I actually just got at my last pelvic floor therapy appointment. She showed me how to do it. And she was like doing it. And I'm like, yeah, it's a little burny. Not fun.
Well, yeah, because you're stretching to the point of max of like how far it can stretch, and just kind of holding it there and training your body for that stretch. But again, there's no one's really studied that. So if it's like something you're dreading, don't worry about doing it.
Yeah.
But
I can't do it. Because the baby's so much in my ribs, like reaching. It's hard for me even just to wipe with my right hand because the baby's like right in the way. I'm not as talented with my left. So I was like, babe, you're going to have to try to do this.
Yeah. And it's great if your partner can help you for sure, but it's definitely not, usually like a sexual experience.
No. No.
And then the other thing is a lot of midwives will do like warm compresses if their clients pushing outside of the tub, and that doesn't have a ton of evidence to support, like it's not harmful. Again, it's not been shown to be super beneficial either, but it can sometimes feel really great. Like it can be really relieving of some of the burning. And it can be like a good grounding technique of like, okay, this is where I'm pushing, or like I'm pushing up against this compress, but it's going to be really individual, and some people don't need it and some people feel like they really want that. So
what about being coached to push versus not? Could that affect tearing?
Yes, absolutely. Sorry, I don't even think of that as like an option
because you don't coach people.
I mean, there's time and place for some coaching.
Yeah, for sure.
But there's the purple pushing, which is where traditionally, again, this is like standard of care, is where they tell a client to hold their breath and they count for 10 seconds while you bear down and push as hard as you can for 10 seconds. And the problem with that is that you're decreasing blood flow to both the birthing person and the baby. And so you tend to see a lot more variables, and you're actually not speeding up the birth at all. You're just kind of draining the oxygen stores of both parties. And that has been shown to, I think, increase tears. I can't actually know if that is evidence-based or not, if that actually does worsen the tears. I know that it doesn't speed up labor, and I know that it doesn't it's not great for the baby. But
I feel like I heard that it does because you're kind of forcing instead of letting your body guide it.
Yeah, I think a lot of manipulation
sure.
at the end too. So like normally the only coaching that I usually do is when the baby is close to crowning, as I tell our clients to slow down or to stop pushing and just kind of let their body slowly, like just not to rush that part. That slow stretch is really helpful for preventing tearing. Right. And that's the Ring of Fire, which is not
Does
fun.
not sound fun.
And it only lasts a few seconds. Usually with the next contraction, the baby comes out. But that slow easing out rather than like kind of rocketing the baby out can be really helpful in kind of controlling that slow exit.
Mm-hmm. Which also might be different, I feel like, with an epidural or not.
Oh, for sure. Yeah. So when you have an epidural, you may need more coaching than typical. It doesn't need to be purple pushing.
Right.
Coaching can be, you don't have to hold your breath. Just, do you feel this? Try to push here. Like, let me guide you. And if counting is helpful, we can count to maybe 6. 6 seconds is more of a natural duration of pushing. That people would push normally if they weren't coached. So if you are coaching, you can limit it to 6 seconds. And then kind of giving feedback, that's all really helpful and much different than a purple pushing kind of standard. But epidurals, because you're not necessarily feeling all of that automatic urge to push, sometimes you do need more coaching and to try different positions and all of that. But usually if it's spontaneous, unmedicated pushing, you're going to find a position that works best for you. It's going to be very automatic, like you feel like you're throwing up, but in the opposite direction. You can't really control it. It's just this automatic urge to bear down, and we just kind of encourage our clients to go with that and push as long as it feels normal. And try different positions and doing all of that. So upright birthing is great for moving the baby down. But like I said, sometimes like in that, I think on like a birthing stool is where I see the most like intense tears. So I think birthing stools are great for pushing, but maybe not actually delivering the baby on. Just a thought.
Putting that in my...
Yeah.
in my mind, don't deliver on a birthing stool. So you are opening up a birth center here.
Yes. Well, I'm not opening it, but I'm the director. Yes.
So for people who might be birthing in the Chicago area in the next year, tell us a little bit about that.
Yes. So we are going to be located in Burr Ridge, which it will be called the Burr Ridge Birth Center. We hope to open in the fall of 2020. The building is currently under construction. We're approved for that. So that's been really awesome. And we are just like so thrilled to bring this option to families in this area because this is only the 3rd birth center in Illinois and it will be the first in DuPage County. So we are building our team right now and developing all of the evidence-based policies and procedures. And I'm just so excited to finally work in an environment where I get to be like 100% authentic midwife and not have some of those like I was talking about before, like the standards of care that are based on tradition rather than evidence. So we're really excited to make this like a really safe, evidence-based place for everyone that wants it. And for those listening, I think sometimes people think birth centers are not going to be affordable or not going to be an option for them, but we will be in network with most major insurers and we will take Medicaid. So come see us. We would be happy to care for you. And it's a birth center, but we're also going to be providing all of the midwifery services that I talked about earlier, like gynae care, pap smears, annual visits. It's not just for birth and pregnancy. So for those who don't know about birth centers, they're amazing. Go ahead and look them up. They have even more incredible outcomes because they're midwife-led and midwife-run. And I'm really excited for
which actually, I'll include the evidence-based birth article. So midwife-led and midwife-run facilities like birth centers have the best outcomes over hospital or home birth. Yes. It's basically the best model of care.
Yes.
For women.
Yeah.
So I'll link that article in the show notes so you guys can read it. And anything else that you want to leave us with?
No, this was so great. Thanks for inviting me. It was so good to see you and talk fun things. This is the best.
Our favorite things.
Yes, this is
birth. Yeah, awesome. Well, thank you so much for coming on.
Thanks, Liz.
I'm so glad that she was able to come on and just to take the time to come on. I know that she's in the middle of opening a birth center, and life can just be kind of crazy. But I'm going to leave a bunch of research in the show notes for you guys, because I know that we talked about a lot, but it's really important for me to give you guys research and give you guys reliable sources. So I always kind of refer back to evidence-based research, because they bring on studies that have been just extensively gone over, and they're not biased at all. So they just bring the research to you. And one of those is the midwifery model of care, and how that is basically where the best birthing outcomes are midwife-led, midwife-run centers. So birthing centers are kind of the best place to have a baby. If you are, obviously there's some risk factors that might not be an option for you. But based on all the statistics and research, it shows that those are the healthiest births, babies, lowest rates of unnecessary interventions and things like that. So I'm going to be linking a bunch of articles in the show notes. So make sure that you guys take the time to read those, check them out, share them with somebody who might be thinking of having a birthing center birth, or just looking into what their options may be. Well, you guys, next week I have an episode already for you guys, but I'll be 40 weeks next week. So maybe I will have had my baby, maybe not. I don't know. But either way, there will be an episode out for you guys. And I am super excited to continue to share this next chapter of my life with you. I'm getting so excited to have this baby. I'm just pumped. I'm really looking forward to the birthing process. It's things that come after that I'm like, oh my gosh, I need to get ready for this. But I'm lining up I have a pediatrician coming on. I plan on doing a lot of baby wearing. So I'm looking for a baby wearing expert to come on, because there's actually a wrong way to wear your baby that could affect their hip alignment and things like that. So I'm looking for other experts to come on to help me through this, because I feel equipped for the birthing process, and what comes after, I'm like, I don't even know if I know how to swaddle a baby properly. So I will just be learning as I go, which I heard is basically what all you can do anyways. So I'm super excited to continue to share this journey with you guys, and can't wait for you to hear more information on next week's podcast. Love you guys. Bye.